everybody. The topic of discussion for today is the deltoid muscle. It is a thick, powerful and curved triangular multipennate muscle which crafts rounded contour of the shoulder region. As the muscle is shaped like an inverted letter D, hence the name deltoid. As regard its origin, it has got three parts. Anterior part originates from anterior border and adjacent upper surface of the lateral one-third of the clavicle. Middle part originates from lateral border and adjacent upper surface of the acromion, having four septa of origin. Posterior part originates from lower lip of the crest of the spine of scapula. Fibers from all these three origins are again divided into three parts: anterior fibers, middle fibers, and posterior fibers. Anterior and posterior fibers are parallel, whereas the middle one are the multipennate fibers. Anterior fibers travel downward, lateral, and posterior, whereas the posterior fibers travel downward, lateral, and anterior. Middle fibers converge downward, being multipennate fibers. They increase the muscle mass, increase the strength of muscle. Because of these facts, this becomes the strongest part of all the three parts of the muscle. For insertion of the deltoid muscles, fibers converge inferiorly. They create a short, thick tendon, which is inserted into a V-shaped deltoid tuberosity on the lateral aspect of mid-shaft of the humerus. Multipennate, or the middle fibers, originate from four septa connected above to the acromion. Fibers converge onto three septa of insertion, which is connected to the deltoid tuberosity. Deltoid muscle is innervated by the axillary nerve. As regard the actions of the deltoid muscles, different parts of the muscles can act independently as well as together. Anterior fibers assist pectoralis major during flexion and medial rotation of the arm. Posterior fibers assist latissimus dorsi and teres major in causing extension and lateral rotation of the arm. Middle or acromial fibers are the strongest abductor of the arm from 15 to 90 degree. Notable is that initiation and first 15 degree of abduction is caused by the supraspinous muscle. In true abduction, when acromial fibers contract strongly, anterior and posterior fibers prevent departure from the plane of motion. Notable thing is that deltoid muscle is like three muscle in one, as anterior, posterior, and middle fibers, they have their own action. Relations of the deltoid muscle. First, the superficial relation, which comprise skin, superficial endofacia, platysma, lateral supraclavicular, and upper lateral brachial cutaneous nerves. Anterior border of the deltoid is separated from the pectoralis major. In proximal part, these muscles are separated by infraclavicular fossa, which contains cephalic vein and deltoid branches of thoracoacromial artery. Whereas the distal part, they are separated by deltopectoral groove with cephalic vein and deltoid branch of thoracoacromial artery. Posterior border of the muscle overlies infraspinatus and triceps muscles. Deep relations of the deltoid comprise bones with attachments, that is muscles and ligaments. Number one, upper end of humerus. At the anatomical neck is attached the capsule of the shoulder joint. Greater tubercle with insertion of supra and infraspinatus and teres minor muscles. Lesser tubercle with insertion of subscapularis. Intertubercular sulcus. The lateral lip of this sulcus with pectoralis major. Medial lip with teres major and bed with insertion of latissimus dorsi. Dorsal surface of the upper end of the humerus is related to the lateral head of the triceps. Number two, scapula. Coracoid process of the scapula with origin of coracobrachialis, short head of biceps and insertion of pectoralis minor. Supraglenoid tubercle with long head of biceps and infraglenoid tubercle with long head of triceps. Number two, vessels, that is anterior and posterior circumflex humeral artery and veins. Axillary nerve and its anterior division around surgical neck of the humerus. Shoulder joint with tendon of long head of biceps. Musculotendinous cuff and coracoacromial ligament. Sub subscapular infraspinatus bursae and subacromial bursa. As regard the blood supply of the deltoid muscle receives blood through acromial and deltoid branches of the thoracoacromial artery. Number one. Number two, anterior and posterior circumflex humeral and subscapular arteries. Number two. Number three, deltoid branches of the profunda brachii artery. As regard the clinical anatomy, the deltoid is the frequent site for intramuscular injections. How this and where this injection is given. Patient is asked to sit and keep the arm by the side of the chest, that is adducted, and preferably forearm flexed and in coronal plane. Arm is divided into two parts from tip of the shoulder to tip of the elbow on the lateral side. Injectable is injected preferably at or just below the middle point between acromion and the deltoid tuberosity. Reason being to avoid injury to the axillary nerve, as this nerve travels in upper part of the upper third around the surgical neck of the humerus. For testing of the deltoid, patient is seated as shown in the diagram and is asked to abduct the arm against resistance, which is applied with the one hand. We can feel the contracted muscle by the other hand if needed. Dislocation of the shoulder joint and or fracture of the surgical neck of the humerus may lead to damage to the axillary nerve. If this happens, the deltoid muscle is paralyzed, leading to loss of rounded contour of the shoulder. Greater tubercle becomes prominent. Power of abduction between 15 to 90 degree is lost. As regard the sensory loss, it occurs over lower half of the deltoid in a badge-like area, which is referred as regimental badge. Comments and suggestions will be welcomed. Thank you for listening and watching.